Please go ahead and mute yourselves unless you are speaking. If you are just joining us, go ahead and please put your name and who you're affiliated with in the chat. This helps us greatly with roll call. Additionally, this meeting is being recorded. This meeting will be posted on the website. And then additionally, there will be a transcript that you can access via the YouTube video once OIS transcribes it for me. So probably give me until the end of Thursday and it'll be up on the website. We have about 3 more minutes. Please go ahead and grab yourself a cup of coffee or, go eat that kid's fruit roll up that no one's watching you eat really quickly. And we'll be starting this in about 2 minutes. All right. Welcome to November 12th, the Integrative Care for Complex Populations Collaborative, Medicaid and Medicare adjacent. And I am Janet Herb. I am your liaison to OHA, and we have our 2 chairs, Walter and Jake. And I'll be handing this off to Walter real quick. But one thing I would like everyone to take note, I did send out the invites for 2025 at the bottom of this agenda, which is posted, and additionally, it is on your invite that it has all the upcoming meetings for the next year, which we're super excited to go ahead and present that to you all. And our next meeting, I'm hoping to have information brought to you by Naram, who is going to speak about slums and the data, and then potentially another QIM update and best practices. So I'm going to hand this off to Walter, and I will be quiet, and let me know how I can help assist Walter if need be.
Oh, thank you, Jan. Welcome everybody to the what is this? The November something. Hold on. November 12th. Integrative Care for Complex Populations Collaborative Committee meeting. It's good to be back with everybody. I hope your third quarter was warm and lovely. As Janet mentioned, please put your name and your affiliation and your pronouns in the chat so we can keep attendance. I'm going to go over the agenda and then we will jump right into it. So from 1:10 to 1:45 today, we have Teresa Young-White from OHA to talk to us about the HRSN and the live housing and social determinants. We'll take a quick 5-minute bio break and then we will come back. And I think we're privileged to have Shub here from Predict Health. Shub is the founder and CEO of Predict Health, and he's going to talk to us about star rating and health equity and how all that applies to our DSNP programs. And he'll present to us for about 40 minutes from about 1:50 to 2:30. We'll have time for public comment, maybe some questions for Shub, and then we will all go our ways and we'll be back in February. So let's get going. Oh, and just a reminder that Jake is here as well from Pacific Source as your co-chair. And so I am going to go ahead and hand the microphone over now to Teresa.
Hello, everyone. Thank you so much for having me here today. My name is Teresa Young-White, and my pronouns are she, her, hers. I'm with the Oregon Health Authority on the health-related social needs team, and I'm going to talk a little bit about the housing benefit, about how to request HRSN services, and a little bit of an overview of HRSN services in general. I'll touch on the climate benefit, the nutrition benefit, etc. I just want you to know that I am very happy to be interrupted. I don't want this just to be a presentation and me talking at you. Feel free to either raise your hand, write in the chat, just speak up. And I will stop where I'm at. If there's a question that I'll address later, I might not answer it right that second, but most likely I will. I really believe in answering questions as we go throughout so people have a foundational understanding as much as possible. So I'm not sure if I sent these slides to your chairs and Janet yet. I will send them before the end of the day today for sure. So all right, so a lot of you will know this. I'm just going to do a quick overview though. What are health-related social needs? So this is an entitlement, a benefit for eligible Oregon Health Plan members. So that means if they are eligible for this benefit, they do receive this benefit as long as they ask. It's a little bit different than health-related services and the flexible funds, which I'll touch on in just a sec. There is an eligibility structure though, and it's really intended on reaching folks in what are called HRSN covered populations. These are folks that are either in the middle of or recently have had a major life transition, as well as a couple other groups such as people that have been involved in the child welfare system in Oregon at any age. People have had an open case with child welfare, whether or not they were adopted or fostered or just had an open case, they're eligible for this benefit. And then the other populations are special adults with, or special young adults with special health care needs, starting in January as well. And then there are people being released from incarceration, from behavioral health facilities, people at risk of homelessness, etc. Future slides will show which groups are eligible for what benefits and how, but just to clarify that the climate equipment benefit, housing supports, and then on January 1st, the nutrition benefit is for Oregon Health Plan members that are eligible. And I kind of touched on that already, but this is just another slide to show that there is benefit specific criteria as well when it comes to these benefits. So, I'm not going to stay on that slide longer. So housing and climate are live along with outreach and engagement services. These will, sorry, just was checking the chat really quick. The nutrition benefit will begin on January. I said that already, but just to be clear, that includes medically tailored meals and nutrition education. There is some other pieces of the nutrition benefit that will be launched later in 2025 or potentially into 2026. and that includes pantry stocking and a fruit and vegetable benefit. So, but starting in January, it is medically tailored meals and nutrition education. And one thing that we want to be really clear about, we are under a demonstration waiver. This is the 1115 waiver. This goes through 2027. We will be applying to the federal government for a waiver for 2028 and the future, probably through 2033. It's a hard year for me to say out loud. It doesn't come off the tongue easily, thinking about the 30s here. But we are continuously evaluating these programs and policies. We want to meet the gaps for these members. And so please, if you have struggles with implementation, whichever side you are on, whether it's being a CCO or a provider or an HRSN service provider, we really want to get feedback on what gaps there are and gaps in policies or gaps in access, et cetera. One of the most important things that we talk to folks about is that this health-related social needs is a benefit, and I called it an entitlement, and that is the case. It's a little bit different than flexible funds where CCOs have the ability to fund categories of care, could be all housing. Another CCO could focus strictly on nutrition. Another CCO could provide all kinds of services under flexible funds. But the funds in the flexible funds could also run out potentially. There's a lot of CCO control over those funds, and HRSN is a little bit different. It is standardized over the CCOs and open card. So open card members also are eligible for HRSN, and it is the same rules. So following the same Oregon administrative rules, no matter whether they're in CCOA or CCOB or open card. And I should clarify, I'm saying CCOA and CCOB as for like a health share, Pacific Source, or IHN, and not the actual plans as well, because I know that some plans are called CCOA and B. So I apologize, that was a little bit confusing. But basically, throughout the state, HRSN is standardized and should be equitably administered as well. So housing just went live on Friday. Wait, no, that's a week and a half ago, Friday now, which is really exciting. We hear there is extremely high volume of requests, especially for rental assistance and housing sustaining tenancy services, which is basically housing case management. We also call it tenancy supports. And for rental assistance, people can also receive utility costs and storage fees, depending on their situation as well. So I know in the first couple days, our open card contractor got a request in the hundreds. I think it was 200 and something just in the first 3 days. So, and then we won't have data from our CCOs for a little while, but anecdotally, we've heard that there is a lot of volume, which is fantastic. We know that that is a need, especially for the housing benefit, honestly. I mean, the other benefits are fantastic as well, but housing is one of the biggest crises. I'm sorry. Yeah, but it's a really important benefit for our members to become stably housed, or to stay stably housed rather, can really impact their health and well-being long term. So the other piece of the benefit is medically necessary home accessibility modifications and remediations. We call those home mods to be a little bit quicker on it. And these could be wheelchair ramp installations. It could be grab bars for the showers or bathtub, pest control that the landlord is not responsible for. So something that the member would be responsible for. This could help cover things like eradication of bed bugs and treatment, for instance. Heavy duty cleaning is also something that could be covered, and that is intended to be extremely heavy duty cleaning. I know that it's generally, but not always, linked to some sort of hoarding disorder. So it's those big sort of, I think people call it muck outs as well, helping people really clean their house in an intensive way. And if they needed to have a house cleaning like that and needed to stay in a hotel while that was happening, that could also be covered under this benefit. So I'm going to talk about the eligibility structure a little bit, but then really go into how do you request. How do you request these services? How do you help your members, yourself, your clients, your patients? How do you help them request these services? But first, quickly, no, not quickly, but eligibility. Eligibility is relatively complex. We tried to simplify it as much as possible here. I think this slide looks scarier than it really is. Think about it being a current Oregon Health Plan member. They have to be enrolled in OHP and they have to have a clinical risk factor. So on the left side here, under number 1, that is the list of clinical risk factors for the housing rental assistance and tenancy supports benefits. It's actually quite broad. There's a lot more details and it gets down into like ICD-10 codes and what is acceptable there. But overall, when we think about this, and if you're helping someone connect to their CCO or open card, or you're building program policies and training staff around this, it's important to remember that the clinical risk factor is integral to the benefit, but it's also very broad. So you have anyone under 6 years old, you have people 65 and older, you have pregnant or postpartum in the last year folks, and then anyone with a complex behavioral health or physical condition are eligible for these benefits, as well as these middle here, which are a little bit more detailed and difficult to talk about. So current or past IPV, interpersonal violence experience, neglect, abuse, a repeated crisis encounters, and emergency department use. Oh, and I skipped a piece, but anyone with a developmental disability or anyone that needs support with their activities of daily living or instrumental activities of daily living, ADLs and IADLs. It's really broad when you look at that. And again, it's not intended to be the limiting factor here, but we do need to link all of our benefits under the Oregon Health Plan to an improvement in a health condition. The more limiting factor, I would say, is this number 2, the at risk of homelessness definition. And at risk of homelessness in this situation for the housing benefit means people that have an area median income of 30% or lower for the region. And there is a chart. You don't have to know, nobody has to know off the top of their head what the area median income is. There's a chart that we have posted in our resources online where you can check that and say, okay, this person lives in, the closest city is Albany. It's a one-person household. They need to earn 17,000 and change or less annually to qualify for this benefit. And this income is based on the last 2 months. So they could have, this is part of what plays into, we're trying to impact people that are going through major life transitions. So it's not their past year. They could have lost their job 2 or 3 months ago. And so the last 2 months of income is what applies to this eligibility framework. They also would need to lack sufficient resources or support networks to prevent homelessness. That's really self-attestation by the member. The member is saying, I can't pay my rent. I need help getting resource connections. I need help through HRSN to pay my late rent, to pay some of my future rent. So that would be, them saying, I don't have, a parent or guardian paying my rent. I don't have a rich benefactor that is paying my rent. And then the additional eligibility requirements are pretty straightforward. They need help staying in their current housing. I think that if they lack sufficient resources, it probably leads to them needing help staying in their current housing. So in some ways it could be a little duplicative there. And they do have to have a lease or a written agreement with their landlord. So this is one of those spaces where a member doesn't have to have necessarily a written lease with a landlord of an apartment complex necessarily, though. So they could be living with a family member, with a friend. They could be staying on a couch or a spare room with someone that they know, and they could be eligible for this benefit and be considered at risk of homelessness. And what they would do is they would sign a form along with the owner of the home and say, yes, we're paying them rent. And the idea of this is that someone that is being supported by family when they're going through a major life transition or having difficulties, they could potentially have an easier time of it if they were paying that family member or friend, right? And so the HRSN benefit can help support that situation as well. Okay, unless there are questions, I'll go to this slide, but I don't see any yet. And then we have a really similar, Janet, please.
One question I've been getting in other meetings is how, with this, if somebody's not able to advocate for themselves, so we're working with a dual population for the Medicaid, Medicare, how are they able to request this information? Can there be a proxy, or does the CCO just take a look at the situation if they're unable to articulate their needs?
Yeah, great question. So the member in some way needs to confirm that they want HRSN services. And by member, that could be a parent or guardian that has, or someone that has documentation on file as a member representative. Sorry, that was the word I was looking for. Absolutely. But the member too, like an HRSN service provider or a community partner, could absolutely verbally say, this member verbally attests, they nodded, they need this support. I'm signing off on this. I want to request on their behalf, but I know that they are amenable to that, right? And so it could be just a verbal permission from the member to ask for these services too.
Thank
Anyone
you.
that, okay, great, thank you. George? You're muted, George.
Okay, in order to qualify for the HRSN, they have to become an OHP member, right?
Yes.
So in order to become an OHP member, what is the income limit that they have to not pass? You see where I'm going with this?
Yeah, you make a really good point. We don't use OHP income verification for the HRSN benefit. It is a different income limit. It's a different documentation process. And I know that that's a little bit of a struggle for a lot of folks, and I totally get that. In some, one of the arguments was that the Oregon Health Plan members may have provided income verification a long time ago. And so, even even in a couple of years ago. And so for this situation, I'm going to move back to the slide that we're talking about the income there. In this situation, it basically needs to be re-verified and redetermined in that situation. So,
Okay.
but a lot of Oregon Health Plan members do fit in this income bracket.
So where does someone apply for this HRSN if they're not an OHP member?
It is not a benefit for non-OHP members. So in that situation, if someone is not an OHP member, we'd recommend support through like community action agencies or the housing authority potentially in their region. But if they're not an Oregon Health Plan member, this benefit does not apply to them.
I see. Okay.
So for the home modifications, there really isn't much difference here other than they don't need to be at risk of homelessness and they don't need to provide income verification. The clinical risk factors are the same, and the home modification that's requested must connect to that clinical risk factor. So somebody that has a developmental disability, potentially, maybe grab bars would be helpful for them. That would be a connection there. Someone that is currently pregnant would be another connection. Maybe they are on bed rest. Maybe they need to be in a wheelchair, so they could have a ramp installed. I'm just making up these scenarios, but there has to be that connection between the home modification and a clinical risk factor. And then they need to be part of one of these HRSN covered populations. I won't read exactly from the list because I've touched on those a little bit before, but dually eligible members, I think Janet or somebody mentioned that earlier, individuals that are transitioning from having Medicaid only to having Medicare and Medicaid, so they're doubly covered. Dual eligible, they could be part of special needs population. This is just a lot of different ways to say, dually eligible on Medicare and Medicaid. And they would be eligible, I think it's 3 months before they're transitioning and 9 months after. So there's a year where they're eligible for that as well. And then individuals who are at risk of homeless are still part of this population. They just don't have to have the same income verifications, etc. Young adults with special health care needs also will be eligible as of January 1st, which is very exciting as well. The other piece about this is they don't have to be a renter. They can be a homeowner in this situation and still have approved home modifications as well. If they are renting, there is landlord approval required before they will be able to receive the home modification or remediation. And there's a couple reasons for that, but one of the reasons too, to discuss with the landlord, that's part of the CCO's and Open Card's responsibility, is to decide whether this is the member's responsibility or through something like the American with Disabilities Act, should this be something that the landlord should be installing and paying for and taking care of? This benefit is not intended to supplant other funding spaces, so other funding streams rather. And that could be something like there could be a pest infestation that the member had nothing to do with. They didn't bring it in. It's really the landlord's excuse me, it's really the landlord's responsibility. Other things that require a reasonable accommodation under the American with Disabilities Act would be another piece where this benefit wouldn't pay for, but we could help support the people in the housing provider world could help support through the tenancy supports benefit, advocating for the member, talking to the landlord, and helping the member understand their rights as well. So that could be part of this benefit, well, the housing tenancy sustaining services here. So the idea is not to deny a home modification unless there is other support in place where they can really help the member get what they need as well. Okay, that is all for the housing benefit. And I want to talk about requesting HRSN services and some of the resources out there, but I want to pause and just make sure there aren't any other questions on the housing benefit first. Okay, great. Okay, so how do you request this? How do you support? Oh, George, go ahead.
My next question would be real quick is who sets the policy through OHA on income limits?
That would be our housing leads and our leadership level. So, sorry, I have a little bit of a cold. So the policy on the income limits was set, it's in the Oregon administrative rules, et cetera. And that was done by the 1115 waiver project leadership team. And then of course, it is, well, not of course, but I want to be clear that it was informed by community partner sessions as well as CCOs and other folks. But there was a lot of discussion on the income limits. Also the Oregon Housing Community, wow. OHCS, I'm so sorry. I'm blanking on what OHCS stands for. Oregon Housing Community Services, I think. They are another big partner of ours. They are experts in the housing world, and they also support making these decisions and building these policies and programs. It's been going on for the last couple years, but especially in the last 6 to 8 months. Those were the folks that were developing the policy, George.
Thanks.
Yeah, of course. So requesting HRSN services, this is extremely important. Of course, how do you actually do this? And so the idea is that it is low barrier for folks. Thank you, Janet. Oregon Housing and Community Services. I just couldn't spit that out. OHCS. I really appreciate that. The folks are great over there and they work so hard along with our teams. So, but requesting HRSN services, it's intended to be low barrier. The member can request services. Someone who is working on behalf of the member, even if they're not getting paid for the work like an HRSN service provider would be, but like a granddaughter or aunt or uncle or somebody, family member and friends, they'll be able to help fill out these forms. The only thing is they do need to have confirmation from the member that the member wants these services or from the member's representative. So I'm going to actually open up a couple of these pages here. So we're just going to stick with housing. There is the climate webpage, and the climate equipment request form is also really similar, but let's go with the housing request. And this is how a CCO member would request, or someone on behalf of the CCO member. So down here, how to ask for HRSN housing supports, there's links to all of our CCO housing request forms here. You could call the CCO. You could email the CCO, could stop by a CCO's office and talk to them about it anyway, but this is probably the fastest way to get those services. So once the CCO receives, I'm just going to click on one here, just randomly. So you could go here if you have an all care member, and there's the request form there. And so you put the name, the address, the member ID. They have the name of the requester if it's different than the member, so that's built in as well. And then all these other things. So they could upload the rental agreement, the ID, the proof of income, etc. As soon as the CCO receives this request, they have 14 days to authorize or deny the request based on the eligibility framework that I just discussed. So anyone that is eligible would get approved for the rental assistance. This is an entitlement like I talked about before. If the member does not have all of these things at this moment, they should probably call the CCO and put through their information that way and their request, especially if they need help understanding what documentation that is required for, say, a rental request, which is probably going to be the biggest one out there. Rent is a very big expense for folks, of course. So that would be all cares. And then if you go back here, there's also, as well as all the other CCOs, certainly, there is open card, a form for open card. So open card members email this email here, and they could just email with their information. They don't have to fill out the form. The form, what it does is it helps just streamline the kind of information that the health plan is going to need. So this would be similar to their CCO's forms as well. Sorry, it's taking a while to load. And a member, you could fill out this form and send it to the CCO as well. The CCO is required to accept any HRSN request as long as it has some member information so they can identify the member, a way to contact the member, the fact that the member wants these services and what kind of services they want. So it is written in rule that as long as they have those 4 things on a request, the CCO accepts it and it kicks off that 14-day time frame. And then the CCO would have to reach out to the member to get the rental agreement, etc. We do know that members can be really difficult to get a hold of. And so for people that end up being connectors or HRSN service providers, caseworkers that are supporting the member, we just encourage to fill out as much of this information as possible, simply so it can move faster and more streamlined for the member to get those services. Because the CCO does have 14 days to approve or deny these services, they can approve it more quickly if they have all the information, certainly. So this is what the request form looks like here. I will zoom in a little bit. It's probably kind of hard to see. And so it's split out into what's required. And those are those four things that I talked about. We do want contact information. The OHP ID would be awesome. If not, then it could just be name and date of birth. But one of those is required to make sure that OpenCard or the CCO can identify the member. And then what do they want or need? Do they want rental assistance? So they check that box. Do they also want tenancy supports as well? Do they only want tenancy supports? So they could check the box there. And then either they would sign this, or as a support person, you could say member verbally attested on November 12th at 1:37 p.m. there. There are other pages. So some things are important, like the preferred name and pronouns. Spoken and written language could also be really helpful for folks. So if you have someone, let's say, that speaks Spanish, they filled this form out in English because a community partner was helping, and maybe they know some English, but they really prefer in Spanish. That helps the CCO either or OpenCard get an interpreter or mail out their documents in the appropriate language, of course. And then there's a lot of information based on that eligibility framework I just showed you a few minutes ago, but they don't have to fill this out. We understand it can be really confusing. If a member self-attests to these things ahead of time, though, it might just help speed up the process. So let's say that they have a developmental disability. I have a developmental disability. I check that there. The CCO does not require chart notes or a diagnosis or something from any medical provider, quote unquote, verifying the member's attestation that they have a disability or any of the other things on this list is adequate for approving the benefit request. They would obviously have to meet all of the criteria there. So being part of a covered population or being at risk of homelessness for rental assistance or tenancy supports, etc. The climate form also looks almost exactly the same. And thank you, Janet, for putting that in there. And then when nutrition goes live, it should be the same look as well, the same type of information that is needed as well. I'll just click on one more. I wanted to show you, here's the climate request. Okay, that's not, sorry, hold on one sec. I'm going to go to someone that I know is using, this is a Unite Us form. And many, I happened to click on two that didn't, but I think it's like 8 of our CCOs are using this platform, Unite Us, for their request forms and for the referrals. So you don't have to have access to Unite Us. For those that are familiar with this platform, you don't have to sign up and get a login account to request these. They can just fill out this form and it goes directly to the CCO. So a lot of them will look like this and will be cloud-based. Some of them will be a PDF form as well. So that is how you ask for the services. And like I said, there's 14 days for the CCO or OpenCard to approve or deny those services. They could get an extension for 14 days longer, but only if it's because they couldn't get a hold of the member or they didn't have the documentation they needed from the member. So it would be really based on what the member's needs are, not because, let's say, they are administratively burdened or anything for that situation. Libby, hi.
Hi, thank you. And if you've covered this, I apologize. I joined a little bit late. In utilizing this method for requesting, sometimes the ombuds program, and I'm speaking specifically to that, we receive requests that are not clear whether they're HRS funds requests or now HRSN requests. And when we can tell that it's more HRSN, it's easier to navigate this. If it's both or maybe not clear, do you suggest that we start with this as the first path? Or should we be starting with HRS as the first path through the CCO directly?
Yeah, that's a good question. I'm not 100% sure on that, especially from the ombudsman perspective. So let me think about that a little bit. Because HRSN is an entitlement, it's probably a good place to start there. I would guess, in the sense that if they're eligible, they are entitled to receive those services. So it's a good place to start. And if they are denied for HRSN, they are still eligible for flexible funds, depending on the CCO's coverage of flexible funds, what they're funding, and what funds are available, because of flexible services being a little bit more open and not standardized throughout the CCOs. But
Thank you.
HRSN being an entitlement, if they are eligible and they can go through that structure, that's probably the best.
Thank you. That's really helpful. And then those CCOs that are contracting with 211 info for their processing, do these links go straight to 211 info, or do they go someplace else within the CCO?
So it varies. Let's go back here really quick. I just learned, I didn't know how much CCOs were collaborating with 211 for this. So I'm not as caught up to speed as I'd like to. All of these forms, let me pick, no, that's not the right one. Let me pick one. This one, so this actually, I remember because I saw it earlier. Sorry. Let me go back up. Let's request HRSN services. So this has a form for Unite Us that you can fill, and it goes directly to Pacific Source, but I thought they had, I thought they had, I'm sorry, I might be on the wrong one. A connection directly to 211. It might have been Health Share, and I know Health Share is doing that as well. Yes. So ready to apply. They have this request online directly to 211 info for Health Share, for instance. And then same with climate supports as well there. So it is this form from our link on the OHA website. We just link directly to this form, so you don't know necessarily that it's going to 211 info.
Thank you.
This is a little new here. It's still loading, but yes.
Thank you.
Every link from the CCOs, if it goes to 211 or their own utilization management team, should go directly to the correct folks. I think the ones too that have PDFs, I know Yamhill is one. They are not using 211 info. So this goes directly here. You can fax it. It says please fax. In fact, on the top, you can fax it directly to the Yamhill community care folks. So it is a little different depending on which CCO you're working with, though.
For accessibility for folks who don't have access to faxes, is there going to be possibly a way to be able to turn those in maybe at self-sufficiency offices or?
So we threw that around a little bit, and it's not available to be turned in at self-sufficiency offices, but, well, yes and no. You can't necessarily, you can talk to a caseworker there, and they absolutely would get that over to the appropriate CCO. We've talked with a lot of districts, self-sufficiency, child welfare, APD as well. And so absolutely, but that's not a standardized way. I would say that if someone doesn't, I don't have a fax machine. I don't have a fax on my computer as well. Attaching it to an email and sending it over there, and or just calling them and saying, hey, I want to ask for this. Can you fill out the form for me? That's a possibility as well. The CCO would be able to direct them to a form if they wanted to, but they could also say, hey, come in and fill this out, or yes, I'll take it over the phone as well. It should be any way that you want to request these, you should be able to from the CCO, even if it's verbally over the phone.
Thank you.
Yeah. I'm actually curious if there's not an email on this one, for instance. So that's a really good point there as well, though. I appreciate that. We might need to request that everything has, that they have an email or a contact, etc. Okay. Okay. I wanted to just call out that there's quite a bit of resources out there as well. Oh, and I'm 1 minute over time, so I'm going to just touch on this really quickly. There's our climate and housing web pages. I've kind of navigated straight to the request forms, but there's other information there as well. And then for folks that are not with OHA or that are not with a CCO or etc., becoming an HRSN service provider could be a really fantastic way to get some funds in the door for the work that a lot of partners are already doing. So just wanted to call out to take a look at what it would be like to become an HRSN service provider for you or your partners, organizations out there. In order for this benefit to be successful, we need all the organizations, including the healthcare system, to come together and work together to fill in these gaps for our members. So just a plug for that. And I'm always here to answer questions, especially for potential HRSN service providers. We're doing a lot of road shows out to folks and really working on building the awareness out there with our members and providers. Thank you so much. If there's further questions, do feel free to email me anytime, and I would be happy to either come back or meet with you one-on-one as well.
Thank you so much, Trissa. I'm sorry I figuratively fell asleep on the job and didn't remind or notify you of the time, but that's okay. This was a great topic. It's obviously timely and topical and impactful. Really appreciate it. I'm gonna ask, I mean, we can take 5 minutes and if you need it, please do. But I also want to give people the opportunity to ask Trissa any questions since she's here. And if not, we'll all just take our bio break. Okay, nothing comes up. So we'll see you all at 1:47. How's that? Oh, I'm sorry. That's not accurate. 1:52. 1:52. Thanks, Jake. 1:52. Be right back. Okay, I'm going to assume everybody's back. It's 1:52. So I want to welcome everybody back. And next up on our agenda is the agenda reads Strategic Tool for Quality Star Rating and Health Equity Presentation by Shub. More specifically, he's here to talk to us about member advisory groups in the DSNP space. But those of you in quality and stars know it's all integrated. I want to welcome Shub Gupta, the founder and CEO of Predict Health. Shub, the floor is yours, and just let me know along the way if you need anything.
Yeah, great. Thank you so much for having me, and thank you for that introduction, Walt. Very excited to be here. I'm Shub, I'm the founder and CEO of Predict Health, and today I wanted to share with you a tool and a solution that health plans of all sizes and regions around the country are using to effectively capture very unique member insights about their challenges, their barriers, their issues, and especially from populations that have largely been underserved by typical tools of surveys and other data collection methods. So really giving you a snapshot, a unique snapshot about your membership in an effort to address quality issues, process issues, operations issues, and it's being used widely. So with that, I wanted to jump right in. I'm going to share a few slides. Let me use the share screen. You should be seeing my screen. Hopefully that's working.
You got it.
Get a confirmation?
Yep, we can see it, Shub.
Great, super. Great, so tools, next generation member advisory group, and we plans are using this as a strategic tool for quality, star ratings, health equity, and as Walt mentioned, it's integrated. So whether you're in the dual market, whether you're in just the MA General, Medicaid, as you focus on improving your quality measures, health equity, it really needs a view from the member's perspective, and the solution really looks at providing that in a very unique way. Very quickly about Predict Health. So Predict Health is a member intelligence company, and what we do is we capture, analyze member voice and member opinion feedback, as well as, which is basically what members say, as well as what members do, their behavioral signals, and use that to help payers across the country improve operations, performance, and outcomes. We work with organizations of all sizes and regions around the country. We reach about 20 plus states, working also in Oregon, and really excited to be here today. So with that, let me jump right in. So the member advisory groups is not a new concept. These have been in different flavors and formats across the years, but really has accelerated in importance across the last few years for a few reasons. One is just historically, there's been long-standing requirements, as you all know, in the Medicare, the MAC groups, for the PACE programs has been implemented, for the MLTSS programs, and member advisory groups for Medicare and Medicaid plans. The beginning 2021, NCQA introduced the requirement of advisory groups for health equity accreditation, and a number of organizations initiated that and are in the process of getting that across the years. But a big impetus came in 2023 when CMS required that DSNP market, so all dual eligible special needs plans, to create and manage. They call it an enrollee advisory committee, but really was an advisory group, but with a specific set of requirements. And that has been widely not only launched, but has been enforced. CMS has reached back out to all the plans, and its attention to collecting and ensuring that plans are doing an effective job in managing these enrollee advisory committees makes us think and is setting the expectations around a greater use of these committees across the market. Additionally, if you're in the MA world, the health equity index and data collection started in 2024, and the health equity rules will kick in 2027, 26, 27, with the health equity index reward factor or bonus payments being made. And today we'll talk specifically around health equity and the use of advisory committees in the health equity and the STARS world and the quality world. And we'll take examples from there. Super. So let's jump right into what do the enrollee advisory committees mean, and very quickly for folks who are just joining in. So the enrollee advisory committee that I mentioned was a requirement for DSNPs, and every DSNP was required to establish one or more EAC, which is enrollee advisory committee, in each state of operations. So not just one for the plan, but really one for each state of operations. That created a real challenge for multi-state complex plans, but also it's a huge burden as you think about the reason for this. CMS wanted to recognize that different markets have different conditions, and so how do you understand the details from a member's perspective for each of those markets? Initially in 2023, when this was introduced, there was minimal guidance, and there was a significant lift that was left onto the plans to recruit, design, manage, and act on these EACs. And then 24 onwards, after 1 year of launch, CMS conducted EAC reviews with all DSNP plans, increasing attention, focus, and really providing guidance on how to improve the effectiveness of these. Just a quick overview of the federal requirement as that is applicable more broadly, and just to give a sense of how CMS has been thinking about it, and how different states have also had variations around that. So, as I mentioned, beginning 2023, this rule was introduced. They said the requirements were relatively minimal, saying that you have to set one up. But some of the key guidelines that they provided, CMS provided, was that the enrollee advisory committees had to be representative of the population. So if you have an EAC in different, or you have your dual populations, or your plan cuts across multiple states or multiple regions, you want to have the EAC should be representative of the population in that state or market or region. And that puts a burden on the plans to really identify what does the population look like and what's a representative sample. How do you determine the representativeness of the sample was left back on plans, and that created a fair amount of stress and burden back on the plans in sort of analytics and identifying what to do. The purpose of the EACs, the Enrollee Advisory Committee requirement that CMS put in place, was really driven by very simple logic. The goal here has been really about improving care for dual eligible populations and structuring programs to better serve them. Really, as you're delivering a product, you want to understand the consumer or the customer, and the EACs was designed and determined to be one of the most effective ways to collect that insight. Just reading a few of these points, CMS stated in its requirements that Medicare plans and managed plans derive significant value from engaging enrollees by defining, designing, participating in, and assessing their care systems. The experience that they have had in the past with PACE programs and MMPs were very successful, and they found the input and feedback back from the members to be highly valuable and useful in improving the quality and effectiveness of those programs. Other examples that they've stated in the Medicaid side, in MLTSS side, that advisory groups have historically been able to capture very unique data from populations that have traditionally been excluded from typical data collection. So as our populations have increasing proportion of it faces social risk factors or socially vulnerable, they tend to be missed by typical data collection mechanisms of exit surveys or technology-based or email-based surveys, online surveys that have become more and more of a norm. And this is a large data gap and a vulnerable gap and a risk for plans. So how do you capture that data? So this is where enrollee advisory committees have come in. And the EACs is really designed as a strategic tool to achieve planned governance and improvements in operations. You're able to reach using EACs. It's one of the only tools. It's much better than surveys, because surveys only allow you to ask one question and maybe one follow-up before it gets too onerous. A conversation or enrollee advisory committee or advisory groups allows you to go deep. You can go ask why, to really get to the root cause of an issue or understand what's driving, what are the barriers and challenges the members face. You're able to create an environment of sharing of insight and feedback, and able to reach and engage populations that have typically been unengaged by other forms of data collection, as I mentioned. It's a new channel. It's a rich channel. And what we found is organizations have been using it strategically to capture member voice and also develop programs, policies, and procedures to innovate. And there are organizations that are using EACs well, are seeing improvements in not only reaching new populations that they've typically not been able to reach, but really on improving member experience, benefits use access to care services, coordination of care, health equity, and other aspects of member retention, market competitiveness, and so on and so forth. STARS rating is a big area where the advisory groups and enrollee advisory committees can be useful and very effective. And today we'll spend the rest of the conversation really around how can you use it in a strategic tool to really focus on specific STARS measures or health equity measures that are of risk or of concern to the plan, and really understand and dig deep. How do you create this opportunity back for the plan to improve these quality measures? The common challenges when you talk about enrollee advisory committees or advisory groups is that people have tried, for one, people have tried focus groups in various formats. They tend to be more ad hoc. It tends to be one-off. But in advisory groups are very different. They are more sustained data collection efforts. They essentially create a panel and more deliberate way of collecting data. They create a panel of the population and allow you to re-engage that panel in a concerted effort across the year, across quarters, to get a more longitudinal data, if you will, around an issue, around what's working, what's not. It can be used effectively to test different implementations of programs or implementations of policies that you've enacted and planned. In 2023, when the EACs were introduced, some of the big common challenges that plans had as they were thinking about advisory groups was that recruiting. So there's some of the common challenges that were listed by your peers. Is recruiting members is a big thing. Retaining them into these advisory groups is a challenge. They could be silent members. They show up for the incentive or what have you, but don't participate, so you don't really get real data. And sometimes you get people who will share either their most extreme. So you often get the loudest voices in the room, and that can also turn off some other folks. So how do you create a balance of sharing, or a community of sharing, and a culture of sharing within these groups? And those are all challenges that that plans have faced when they're working through these committees and groups. And this is something that we've been working now systematically with a large number of organizations, and it really developed an expertise on how do you build these more effectively and build it to deliver key outcomes back to the plan, so they can get the insights they need for specific efforts and challenges that they're facing or their strategic goals are. And so after the years of running these advisory groups, in fact, we've run hundreds of these advisory groups across 20 plus states, covering about 600,000 dual eligible members across the country. And in some states there are, like Texas, for example, there are many markets, and the same thing with Oregon. You call it a single state, but there are so many sub-markets within the state itself that you are looking at really multiple types of populations, multiple challenges, and in organizations that we've been speaking with, it really behooves to consider looking at each of those markets as its own ecosystem to understand what the core challenges that members face in that market and running advisory groups or data collection efforts specifically at that targeted level. So we took this experience that we had across these advisory groups. We saw how plans were learning from their members in real time, in a really fast turnaround. Could be once a quarter, could be more frequently, but really in a repeated channel. And we took these learnings, and evaluated how we could use this methodology and approach to really positively impact one of the biggest challenges and opportunities that Medicare Advantage Stars programs leaders are facing today. And so we're really taking the advisory groups. Obviously, if you have enrollee advisory committees, that is, and D-SNP plans, this is a valuable value to you. But if you are looking beyond the enrollee advisory committees, looking at just quality, and you're looking to improve specific quality measures, be it if you're a stars leader in a Medicare Advantage plan, or a quality leader in some of the Medicaid managed Medicaid programs, or any health executive across the state, how can you use this data collection mechanism to really help you address some of these challenges and opportunities? And one of the biggest opportunities facing Medicare Advantage Stars leaders today is twofold. One is the challenge is really the removal of the reward factor for those and we'll describe what that means, and then the introduction of the Health Equity Index in 2027, with data collection starting this year. So this is a big impact for Medicare Advantage Stars leaders today, as it means a loss of revenue with the potential to gain back some of their revenue. But how do you make sure that it's not lost? So a quick primer on the reward factor and stars. So a big challenge that a majority of high-performing plans face is that majority of these high-performing plans will lose a substantial stars bonus, a CMS stars bonus in the Medicare Advantage programs that they and the leadership have really counted on for many years. The average reward factor, which is the bonus that is paid out for certain types of performance, was about 0.28 points on a 5-point scale, star scale. And CMS estimates the average HEI bonus with the Health Equity Index bonus is 0.11. So right there, you can see that there's a loss. So one's going away and one's is being offered as replacement, but it's not a one-to-one. So what we've seen as we've studied the high-performing plans is that every 4.5 to 5-star plan earned a reward factor bonus in 24. And what that means is that more specifically, 90% of 5-star plans received a reward factor 0.4 or above, and none received something less than 0.3. So this is a pretty significant chunk of your stars bonus calculations. And what that, in terms of loss, none of the 5-star plans would have been a 5-star plan without the reward factor. So that means the reward factor that was offered really helped people move from a 4.5-star to a 5-star plan. And 12 contracts that earned 4 stars would not have received the bonus, the reward factor bonus, and they were lost about $400 million. So there's real dollars associated with this. And this really poses a big challenge for organizations that are losing reward factor, which is organizations across the board, is they're under tremendous pressure to find ways to recover the points that will be lost with the removal of this reward factor. The alternative that CMS has suggested as a replacement for the reward factor is the Health Equity Index. And what we found is that Health Equity Index and the improvement of health equity for the social risk factor population, so for the vulnerable population, not only helps you with your stars math, but it's also the right thing to do. And in fact, it lifts quality across the board. So in fact, in addition to the HEI reward, say due to member experience weight measures, plans who target performance improvement in the SRF population, which is the social risk factor population, are likely to see strong gains in the quality improvement measures, which is another way you can earn back some of the benefits. In fact, Plans with strong social risk factor performance and meaningful SRF populations can yield up to 0.4 points back in HEI benefits that would more than compensate or replace the reward factor loss. What's also really heartening is that lower performing plans, so plans that have typically been say below the 4-star measure or 3.5-star measure, can benefit from the improvements in HEI and the SRF population performance, but even those with smaller SRF populations can benefit because of the quality improvement indexes that drive some of the STARS measures. And lastly, this is the bottom line is that HEI improvement, health equity improvement, benefits everyone, not just those that are on the edge or those that are looking to that have large SRF populations. But I believe most folks on this call would qualify with a large SRF or social risk factor population. And so then what this means is no matter what your plan situation might be, improvements in your social risk factor population performance can lead to meaningful STAR quality gains. And it provides a huge opportunity for the potential health engagement index improvement and reward. So what does that mean? So we're going to switch gears now and talk really about how do plans optimize the HEI performance. So if you are a plan and you have a risk, you have a social risk factor population, how do you improve your health equity? And we're looking at how do you improve health equity as measured by specific quality measures. So the health equity index and the social risk factor improvement strategy offers a very unique. This is something that we've worked with plans on, really designed to say there's a lot that you can do. Let's figure out a way to focus on the measures that matter the most and are more near term, and something that we can then use business lens to start improving and then bring all the measures up over time. So you really are optimizing your constrained resources, which is your time, your dollars, your effort, to have the biggest impact on health equity, but also on the outcomes of health equity. So we've proposed a 5-part process to improve health equity. So the first one, and we'll go into each one of these in greater detail. The first one step is really identify which health equity quality measures are on the bubble for your plan. So there are 40+ measures in quality right there for STARS. There are numerous others that the organization and executives identify as well that you would like to address and improve. But which ones are really close to thresholds of meaningful improvement? So find and identify those. So our focus is really identify and prioritize which STARS measures are on the bubble that you can move. The second is once you identify which measure you want to move, you really want to understand the population that drives the challenges and barriers of the population that face those that are limiting improvement for that measure. So really here we've seen organizations may successfully create advisory groups for each sub SRF population. And for health equity, CMS identified the 3 subgroups as being part of the initial social risk factor population, which is the dual eligible population, the population that is the lower income subsidy eligible population, and the disabled populations. And they're not always, there's some overlap, but not there's not large overlaps in many population segments in the country. So looking at each of these separately, because they face challenges separately, they may face different barriers separately for each measure. How do you create and understand advisory groups for each of these groups? Once you have created these groups, how do you create a mechanism for targeted feedback and data collection and insight collection around what's working, what's not, what are the challenges and barriers for each of those subgroups? And then prioritizing the barriers to say which ones are the most impactful, which ones are most meaningful, and identifying the root causes of what causing those barriers for each of those population subgroups. Often there may be some overlap that can be addressed, but really recognizing that you can address only a few at a time. So prioritizing which ones to focus on that have the biggest impact across multiple markets and multiple subgroups, social risk factor populations, will be the most meaningful for you and for the plan. And then once you've identified which ones to focus on, is developing a targeted and prioritized strategy here. So let me pause here and see if there are any questions before we go into each one in greater detail.
13 minutes, Shab.
Okay, I'll keep moving. All right, thank you. So optimizing your targeted measure, optimizing identifying the targeted measures to focus on. When you're looking at a health equity improvement, there's both a defensive and an opportunity and a risk evaluation. So for every measure, so here we've taken breast cancer screening, which is one of the STARS measures. You want to prevent slipping. If your measure is really on a threshold line, you want to prevent falling below that line, or if you're under the line, you want to be able to move above the line, because the way health equity for CMS's purposes, health equity index is calculated is it's a 1 point above and 1 point below the threshold, loss of 1 point, so it's equal weighted. So you really want to make sure that you don't you move in the right direction. So simple steps: identify your bubble measures by really looking at which ones are opportunities, so which ones are really close to the line on, just under, as well as those measures that you're just above the line on and at risk of falling. And once you select those measures as the areas of focus. Simple way to narrow down your attention and areas to focus on. The next is really understanding your SRF population. As I mentioned, CMS has identified social risk factor population as 3 groups: your proportion with dual eligible, proportion who are disabled, and proportion who qualify for low-income subsidies. Each of those are distinctly different groups, and we know they all face different barriers and challenges, and depending on the measure itself, they may react very differently to policies or procedures or programs that you put in place. So understanding what exactly is driving, what are the root causes of the issues there for each of these subgroups is critically important. Once you identify the subgroups and you've been able to determine what measures you want to focus on, collecting insights. So using advisory groups to really enable the data collection. So running an advisory group, a panel for each of those subgroups, be it the dual eligible population, which organizations are already doing through the enrollee advisory committees, which is one part of it. But you can roll that up and make that part of your larger health equity and STARS improvement strategy, because you can add similar groups to focus on the disabled population if that is not dual eligible, or the LIS population, which sometimes is distinctly different from the dual eligible population, not clear overlap. How do you, by really understanding those subgroups, will help you understand what are the barriers, common barriers across, distinct barriers for each of the subgroups, and depending on your proportion of your population, you could develop, identify the root causes and root cause analysis around what's driving some of these barriers by segment, by market, by region, by local vendors or benefits providers that you may have. And then once you've identified the barriers and the root causes you want to address, putting it all together. So we work with organizations to help really not only identify the barriers in the advisory groups, using advisory groups, but also working with the teams plus their advisors, be able to put together what is the root causes, prioritize them, and then prioritize action items that help you address the root causes in a much more sustained way. Solving a root cause will address an issue for a longer term, as opposed to just solving a symptom. And the approach and what's different from traditional approaches in the past that organizations have tried and have always found this to be a challenge is that the advisory groups that we're looking at is really helping you solve for that last mile, really capture the insights about the barriers, the challenges that subgroups are facing at the local market level, and putting that in context for the larger population. So you as an organization can take decisions with confidence, business decisions with confidence, as you think about what proportion is going to be impacted by this decision, and how effective is it in terms of improving certain quality measures, certain HEI, health equity measures, and what have you. And so the advisory groups that we've introduced and implemented and now offer for STARS improvement and health equity improvement is really around the next generation of advisory groups. But really leveraging these insights around from across the states, across the markets, across the market types, you're able to create these groups that have 4 key features, and that's really important because one is representative. It is really important that the advisory groups that you have are representative of your population in the market that you're looking at. Because if it's not representative, you will have less confidence in the actions you're learning and the insights you're getting and the actions you're implementing. That'll impact the whole population, because you really want to know, is it a good unbiased sample of your group? And data and analytics can help you do that. The second thing is that advisory groups are actually quite timely and relevant, far more timely than surveys, far more timely than any exit surveys, for example, or other CMS mandated data collection mechanisms. It allows you to get into a market within weeks, capture insights within weeks, and react to it soon after. If you do it right, and not like a focus group, but if you look at it like a panel, looking at it like an all ongoing data collection effort, they're far more easier to recruit for and put together. As well as this is a new set of requirements for plans, and so there are organizations that have built this up to be far more scalable. So our organization, we use technology and data to really make this much more scalable and cheaper for organizations than focus groups typically have. So these tools give you an advantage when you think about data collection for capturing insights and feedback around the barriers that specific subsegments of your population face, and especially when those subsegments are the ones limiting quality improvement or challenged with quality of your plans, really understanding what are the barriers, the why behind it. Key things again is that they're targeted and representative, and this is really, I cannot stress on this more. In fact, this is something that we've been working with CMS on and sharing detail around how do you create a more effective representative sample for each subgroup that you work with. And we use tools and data to help you very quickly get a read on it. Panel management. Advisory groups are not focus groups. Focus groups are one-off meetings or events that you may put together on a specific piece. And anybody who's run market research or focus group will tell you how hard it is to recruit for those events. When you're looking at advisory groups, you're creating an ongoing panel of individuals that's representative of your market, and you recruit from, and you keep that panel warm, you engage with them, you share feedback of what they've learned and what other meetings have learned. And they're a group that in many ways our clients and organizations have really created a culture of feedback that allows you that they are aware of more attuned to some of the issues that they're facing. And so when you are engaging regarding feedback, they're much faster to recruit from, and they provide a much more deeper understanding around the issues, but also more longitudinally, so you can see how it's changing over time, but the things that you're implementing are working or not. And then lastly, the tools and technology that is available to assist you for recruiting, engagement, management, logistics of these advice groups, because it brings together, requires a varied number of skills, and to have all of that at your fingertips to be able to manage that effectively gives you a sense of visibility, transparency, and control over it. With that, there's more detail we can get into around the data analytics, but I wanted to actually see if there were any questions. I know we're coming up on time, so 4 minutes to go, and and can definitely answer questions later as well. So turn over to you, Walt.
Thank you so much. Yeah, very much appreciated. Yeah, George, I know, George, you had your hand up. I think you had a question for Shub.
Yeah. My one question is, what does CMS look at in order to create points for Medicare?
Right. So when you say points, I'm assuming you mean the STARS evaluation points? Yes. Okay.
Yes.
So STARS is a hot topic these days. It's always been. But STARS measures are driven by several 40 odd submeasures that CMS has identified and rotates in and out over time. Those measures are bucketed into different groups around member experience. So there's collected through CAPS, HEDIS measures, admin measures on performance. So they really try to look at the overall operational performance, as well as some small number of outcomes around quality. And so this is really an evaluation that CMS has implemented, and there's an entire set of teams, and there's a lot of research put behind it. The specific measures that affect us is for every year or every few years over a period, CMS requires a collection of data around each of these measures. They tell you what they are collecting, and they'll collect the measures. And then once the measure collection is over, every year to determine the next year's STARS measures, they have their evaluation method that will draw a threshold and will determine the cutoff points for each of the measure levels. So you have 5, 4, and what have you. And it's I know I'm giving you a very, very high level view, but there's a lot of detail behind each of these measures, what goes into it, and how organizations fall out in each of the measures and how they're all rolled up nationally. And it's a lot of money driving, a lot of decisions made as a result of it, and a lot of blood and sweat spent on this area. I'm happy to share links and more detail around how this is calculated on the CMS side and some of the other resources that are available.
Thanks.
Thanks, George. Thanks, Shub. We've got a minute, but I would say that it's conservative. We can go over that. Does anybody else have any other questions for Shub while we've got him? There was a request in the chat, Shub, for the deck. I think we'll be able to share that with the minutes and such. There was a question about what were you referring to by people who qualify for low-income subsidies. I think we answered that. Basically, straight MA, Medicare Advantage, low-income subsidy. Anything else from the committee? Okay, if not, thank you so much for your time, Shub, and your expertise and your just what you've provided for us. Really appreciate it. Yeah, thank you.
Thank you so much for having us, and thank you all for the introduction, the committee for the introduction. Really enjoyed it, and happy to answer any questions. And you have the material, but this is a really exciting area. And what's really exciting is the ability to listen to these your members, honestly, for the first time in a systematic way, and then be able to identify opportunities to improve quality, operations, performance, and their experience, which is ultimately what drives our really exciting outcomes for us.
Thanks, Shub. We got a hand. Libby.
Got a hand.
Thank you. Libby Riscon, Senior Ombuds with the Oregon Health Authority. I just wanted to also point you to the Ombuds report, and those are available on our webpage with OHA, and those include our recommendations to the Health Policy Board, the Director of OHA, and the Governor. And that's based on member voice and experience with Medicaid.
Huh.
Thank you.
Absolutely, that's great. Thank you so much, Libby.
Okay,
Jennifer, I just want to note that in the DSNP contracts, we have an allowance in Oregon that DSNP member committees can be aligned with your CCO committees. They could be a subset as long as they meet the federal requirements. So those of you who've had very active CACs for many years, there's an opportunity to create alignment with your CAC and with your community work that's going on there. So that is in our DSNP agreements for DSNPs.
thank you, Jennifer. Great. Okay, well, it is, let's see, it is public comment time. We've got about 28 minutes for questions and public comment. I just want to say really quickly, I hope everybody enjoyed both great topics today and presentations. And we're as your chairs, we're encouraging you to provide us with ideas. Of course, we've talked a fair amount in the last few committee meetings about sharing best practices. So please get those to us. Jake, Janet, myself, we're happy to hear it, and we'll help set up those agenda items. So I don't know, Jake or Janet, if you have anything to say before we just straight head up into the public comment question section.
No, this has been a great meeting, but I will step back and let others speak if need be.
George, you're up. Sorry. George, you're up.
I do have a question, Mr. Chair. At one time, 1 or 2 years ago, CMS in Washington, D.C. has held a meeting across all 50 states, or 51 states, pertaining to NEMT and getting their feedback on medical transport. Do you know if CMS in Washington, D.C. will be throwing another meeting or not across all states? Or how could I find out the information about that?
I'm gonna throw out a lifeline if anybody knows anything about what George speaks to. I wasn't familiar, George, with the national, I assume NEMT. Ellen, if you can help here.
George, you can't see me. I have a weird camera right now. I'm so sorry. Maybe you can see me now. I don't know. I think I know you from some other work groups that we've been on together, George. My name is Ellen Pinney. I'm principal ombuds for the Oregon Health Authority, and there is work going on in Oregon. There's a technical assistance committee that is still recruiting folks who are interested in improving non-emergency medical transportation, George, and that is the committee I would turn to ask your question. What's happening at the national level? To try to wrap heads and minds around how we make this service work for Medicaid clients who, as many of you know, do qualify for non-emergency medical transportation as a benefit for Medicaid, a Medicaid benefit.
Well,
I'll put my name in chat. George, you can reach out to me directly, and I really appreciate that question.
I was at their first meeting, and I was told somehow that it was going to be another meeting of all the states together. So that's what I was wondering about.
I don't know how to say this. I think there's a lot hanging on what's happening in transition in January right now. So, George, again, I'm going to put as soon as I get my address together, I'm going to throw it in chat. Please reach out to me directly and I'll see what I can find out for you. Okay. And anybody else who's interested.
Thank you.
Thank you.
Anybody else out there in the Teams world have a public comment or question for the committee? Okay, well, that sounds like maybe the end of our November meeting. I don't know, Janet, if you have anything to say, or Jake. If not, see your face, Janet.
No, I'm just saying, I hope everybody has a wonderful, warm holiday season. That's all. And
Yes.
stay, and hopefully the HSRN continues to, will help people in the way we want it to help people moving forward. I think it's going to be a big, beautiful impact. And thank you to Shub for a beautiful presentation as well.
Echoed. Yes. Have a lovely holiday season, everybody. And we will see you on February 11th. Thanks, Shub. Charissa as well. And from Jake and Janet and I, bye.
Thank you very much. Bye-bye.
Happy Thanksgiving and Merry Christmas, guys.
Thanks, George.
To you all too.